Imagine this. A 75-year-old man is completely independent. 6 weeks later, he's agitated, disoriented, and living in a fractured reality. This isn't some rare textbook case. This is the clinical challenge of dementia with Lewy bodies. Dementia with Lewy bodies, or DLB, is a true master of disguise. In this explainer, we're going to equip you with the clinical tools you need to recognize and manage this tough diagnosis. We're pulling back the curtain on one of neurology's great imitators. So let's start with a clinical question that could change your whole approach. We're all trained to link dementia with memory loss, but DLB challenges that core assumption. It makes us look closer at what cognitive complaint really means. And here's the second question that gets right to the heart of this disease. This isn't the slow, steady decline we see in other conditions. It's more like a flickering light. Understanding why that light flickers is absolutely essential for a diagnosis. Everything we're talking about today is based on a fantastic paper from the journal Practical Neurology. It was published in 2006, and it's titled Dementia with Lewy Bodies, a practical guide to clinical diagnosis and management. And as always, you can find the links to the bibliography in the description below. All right, here's our game plan. We'll start with a diagnostic challenge, then we'll get into the 4 cardinal signs. Think of them as the fingerprints of DLB. We'll explore its different disguises, fill up your clinician's toolkit, and wrap up with a really clear clinical action plan. So let's jump right into that diagnostic challenge, looking beyond simple memory loss. The cognitive signature of DLB is so unique, but it gets missed because patients and their families almost always lead with complaints about short-term memory. Okay, now this slide highlights the fundamental difference. With Alzheimer's, you've got a true storage problem. The memory is just gone. But in DLB, it's a retrieval problem. The information is still in there, but problems with attention and executive function block access to it. Often, a little prompt can bring it right back. That's why you have to probe deeper than just forgetting things. You need to ask about planning, organizing tasks, or getting lost while driving. Those are the real clues. Building on that key distinction, let's get into the 4 cardinal signs. These are the clinical fingerprints that, when you find them, point straight to DLB. So here they are, the 4 core features: cognitive fluctuations, visual hallucinations, REM sleep behavior disorder, and Parkinsonism. Those cognitive fluctuations, that's the flickering light we talked about. These are wild, spontaneous swings in alertness that can last for seconds or even days. They're an early sign, not like the sundowning you see much later in Alzheimer's. Now, let's zero in on a really powerful predictor: REM sleep behavior disorder, or RBD. This is way more than just restless sleep. We're talking about someone physically acting out vivid, sometimes violent dreams, because their brain isn't paralyzing their body during REM sleep like it's supposed to. What's incredible is that RBD can show up years, sometimes even decades, before any other symptoms of an alpha-synucleinopathy, like DLB. And here is the objective proof. This is a polysomnography, a sleep study. You're looking at the electrical activity of muscles during REM sleep. Normally, this line would be flat, but here you see all this activity? That means the patient is physically moving, acting out their dream. This is the absolute gold standard for diagnosing RBD. But you're not always going to have a sleep study on hand. So how do you sort this out in the clinic? This chart is your guide. True RBD usually happens in the second half of the night, when REM sleep is most common. This helps you tell it apart from things like sleepwalking, which happens early in the night, or just vivid dreams from something like sleep apnea. Nailing this distinction is just critical. Okay, now we're moving to the trickiest part of diagnosing DLB, its disguises. The disease doesn't always show up with the classic cognitive or motor signs. Sometimes it wears a completely different mask. And this slide just says it all: reduced dopamine transporter uptake, which points to the Lewy body pathology underneath. This is exactly why DLB has to be on your differential for any older adult who comes in with these syndromes. So you've seen through the disguise. You've unmasked the great imitator. What's in your toolkit for diagnosis and management? This is where really sharp clinical practice can make a huge difference in your patient's outcome. When you're managing motor symptoms, it is a delicate balancing act. You can use levodopa, but you have to live by the rule: start low, go slow. The response often isn't as dramatic as it is in Parkinson's disease. But dopamine agonists, those you need to avoid. They have a really high risk of making the cognitive issues and the hallucinations much, much worse. And this right here, this is probably the single most important management tip you will hear. Up to half of all patients with DLB can have a severe, sometimes catastrophic, reaction to antipsychotic drugs, especially the older, typical ones. It can cause worsening confusion, Parkinsonism, sedation. It can even be fatal. This is a life-threatening risk that every single person on the care team needs to know about. We've covered a lot of ground, so now let's boil it all down into a clear, powerful clinical action plan you can put into practice right away. Here are your 3 key actionable points. First, always probe beyond that initial complaint of memory loss. Your job is to uncover those deficits in attention and executive function. Second, you have to actively screen for the core features. Patients will almost never volunteer that they're having visual hallucinations or acting out dreams. You have to ask directly. And third, always maintain a high index of suspicion for DLB when you're looking at a case of unexplained delirium or new psychosis in an older adult. And to make this super easy to remember, here's a little catchphrase. To unmask DLB, check the 3 R's: the patient's rhythm, the reality, and their reaction. Rhythm is for the fluctuating cognition. Reality is for the visual hallucinations. And reaction is for that critical sensitivity to antipsychotics. Rhythm, reality, reaction. It's a quick way to keep DLB top of mind. At the end of the day, making an early and accurate diagnosis of dementia with Lewy bodies is not just an academic exercise. It's a crucial chance to avoid harmful medications, to start supportive therapies, and to give patients and their families a roadmap that can truly alter their entire journey with this disease.
The disclaimer and bibliography are in the description.